Well, hello. I'm your anchorman and host, Matt Young, and this is our Refractive News Roundtable addressing secrets to happy presbyopic patients. Joining us is Dr. Amir Hamid in the United Kingdom, Dr. Andre Philippe in Romania, and Dr. Janban Chan in Malaysia. We've got a great group of doctors from west to east, and let's get ready to rumble. All right, gentlemen, how are you feeling? Dr. Janban Chan, how goes it?
Nice to meet everyone. How's everyone?
Doing well here. Dr. Hamid.
Yeah, great. Yeah, it's all good here. We're gradually emerging from lockdown. Really excited for the next hour of stimulating discussion. So thanks for inviting me to participate.
And Dr. Andre Philippe, you're waiting there with bated breath next to your horseman statue. How are you?
Exactly. Everybody's great. We are waiting for the summer and to have hopefully a more normal life. And in the meanwhile, nice meeting you all guys. And I'm looking forward to have a very nice chat.
Well, that's great. Without further ado, panelists, here's the first topic of discussion. How do you treat and manage presbyopic patients? So I'd like to go to our studio and say, let's share that first slide demonstrating a patient's lifetime and the options for patients in each age bracket. Gentlemen, today I believe we're going to be focusing in this 45 to maybe roughly around the 55 age range and presbyopic corrections in between. So I'd like to go back and start with you, Dr. Hamid. Can you please go ahead and share your slides across? Presbyopic correcting IOLs. Tell me a little bit about what's going on here.
Okay, so I'm Amir Hamid. I work in London, and I'm the medical director for the Optegra Group in London. I do a significant amount of refractive surgery, including laser vision correction and the use of presbyopia correcting intraocular lenses. That's the my financial interest declarations at the top right-hand corner there. You know, I use a huge number of intraocular lenses and I tailor them to my patients, but I keep coming back to main ones. And that's really based on the technology behind the lenses and also the patient's lifestyle needs. So someone that has a near dominant type lifestyle and it doesn't drive too much at night, is not occupational driver. I use a trifocal lens with 3 points of focus, and that really does give high degrees of spectacle independence and very, very happy patients, basically. With the Atlara lens, I'm targeting patients that have a more distant to intermediate type lifestyle. Most people still will get a high degree of spectacle independence. But what is important is there's no real compromise in their distance vision, and night vision is exceptionally good as well. The other interesting aspect of this lens is aberration neutral. So I do use it a lot in post-laser vision correction patients as well. So that's my contribution for the moment. We can move on to the next presenters.
Fantastic. Well, thank you for presenting that. We're going next to Dr. Chan. Take it away.
So I'm Dr. Chan from International Specialist Eye Center in KL. I do a lot of cataract refractive surgery as well. I don't really do presbyon, but I do LASIK and all. So my topic is on mix and matching IOLs. Yep. So basically, the best lens that you have would be an amateur 21-year-old man or lady. You can actually switch from far to near vision at any time of both eyes, individually on each eye, at any light condition. If you have presbyopia, if you have cataract, then you have to get it replaced. So there's a lot of IOLs that is available now, but there is no one perfect IOL that provides all the focal points with optimal quality of vision without any side effects. So what mix and matching does is that it sort of just fill up whatever that is actually missing. Let's say you have done but in the first place though, I wouldn't do it routinely to all patients. If you have a first eye that is you're happy, you would just maintain the same IOLs. But if let's say the the first eye, the patient is not really that happy. What happens next is that you're going to want to replace it with some other IOLs, mix and match, so that you can actually fill in the gap. So there's a wide range of choice of IOLs that you can use. And there's different properties of the lens. You got to understand how a lens works, which I may already just mentioned just now. And one thing though, is that you must tell your patient not to compare their eyes. You need to see with both your eyes open. So this is an example of how it works. If you have a patient with a monofocal in, let's say the first slide, the first man on top, you can see far, but patient complain that you can't read. Back then, it was a no-no to have a monofocal and the trifocal sort of thing, but I have tried this and it's actually works pretty well. Just ask the patient not to compare your eyes, and you should be able to read and you should be able to see far as well. In a patient that has an EDOF in and they're not happy with reading, you can actually do a trifocal in. The same goes to the next one, which is a monofocal, but the patient doesn't really like any of the glaring and all. The EDOF would do a very good lens. The Elara will be a very good option to that. It gives some reading to the patient as well. And finally, if let's say you have a patient with a trifocal and still can't read, you may want to get a patient with a bifocal so that you can at least read. As in the high plus, then you can read smaller fonts then. All right, I'll pass it to the next speaker, Dr. Philip.
Dr. Philip, indeed, we're ready for you to dismount and give us your thoughts on the matter.
About what Jen Bond said, that in mix and match, you don't have to compare the vision of the two eyes. That's exactly hitting the spot on my topic, because I'm going to talk about Presbyopic. So I'm a cataract and refractive surgeon. I work at AMA Optimex Eye Clinic in Bucharest, Romania. I use Atelisa since 2008, and then I started to use Lara when it came out on the market. But my idea is that, presbyopia is a real thing, and it's the first sign that people feel that they really feel that they are getting old and they are starting to need help. So I don't think that there is a perfect solution for treating presbyopia, as you all know. And the idea is that the lens in the eye everybody knows, loses the ability to accommodate. So what Presbyopic does uses spherical aberration to boost the remaining accommodation capacity of the lens. So basically, you treat the dominant eye to see very well at distance and in intermediate, and then the non-dominant eye to see very well at intermediate and near. So that's why you will have a blend zone in the middle. So the fusion of the two eyes gives the patient the ability to see at the whole systems, reading, intermediate, and far in one continuous vision. But the idea is not to compare. Choosing, because this meeting, this webinar we are having, it's very interesting, because basically in my mind, I think we can cover the whole range of solutions that we can provide. Basically, we started to perform Presbyopic in 2019, and these were our first patients. At the beginning, and we still do that, but we were paying a lot of attention to the people we choose to be. We wanted to find the best candidate for Presbyopic, because it happened to us before. We brought Smile in Romania, so it happened to us with Presbyopic. We brought Presbyopic in Romania, so because of that, we had to pay attention a lot on how we place it on the market and how the outcome will reflect on people talking about this, and making referrals. So all the patients were very well, very attentive, selected. in order to have the good outcome. And our results in the first, I chose our first 50 cases were very, very pleasant, and the patients are happy. That was my topic. So now we can continue with the discussion and questions.
Well, we appreciate all your thoughts, gentlemen, but we're going to actually throw it over to the polls to see what our audience thinks now, okay? All right, so we have a poll here. Poll number 1. Now, audience, do you treat presbyopic patients? If so, which treatment option do you personally offer to those patients? That's the question on the floor, and we have voting in progress at the moment. We're gonna wait, maybe about 10 more seconds. I see the results are filling up. It looks like I'm using presbyopia correcting IOLs is going to be the winner. What do you gentlemen have to say about that?
Absolutely. I think that probably reflects what my practice was, and maybe Andre's practice was a few years ago. We were mainly using presbyopia correcting intraocular lenses. What I would say to that is there's been a gradual change in the philosophy in presbyopia correction, in that we would like to maintain a patient's clear lens for as long as possible before providing an intraocular procedure. Number one, because visual quality is no doubt better, and particularly in the younger age group. It's a much less invasive procedure to do a laser procedure, and the safety profile is amazing, with very high rates of patient satisfaction. It's also very easy to do enhancement if you need to. That's my view. So I think, yes, presbyopia correcting intraocular lenses can give you excellent results. But I think if you do have the opportunity to start doing presbyon, for instance, you will find that not only will you have high degrees of patient satisfaction, less chair time, but also it opens up a higher number of patients for you to offer presbyopia correcting treatment to.
Fantastic. Well, we don't have time for other comments on this one, so we're going to go right to poll number 2.
Sorry.
Thank you, Dr. Hamid. Poll number 2, let's bring that up. Let's end this poll and bring up the second poll. All right, poll number 2 is now in progress. What are the factors the audience considers to choose the right treatment for your patient? And these are lens-based versus corneal-based approaches. Audience, lock in your votes. America, Europe, Asia Pacific is locking in at the moment. We're looking forward to seeing these results from around the world. All right, gentlemen, just to let you know, let's see here. It seems that the individual decision from patient to patient is moving ahead, followed by condition of the lens, i.e. cataract, followed by patient age. Do these results seem surprising at all to anyone?
It's an individual decision. As we said, there is no perfect solution that fits everybody. So it's our job to try to consult our patients and help him choose the right path. Yeah. So I think that's the most important point. And of course, as I was talking about presbyon can treat non-cataract eyes. So if you have cataract, we have great multifocal lens here on the market, so we can use them.
I think there's no right answer to that. It's more of the patient's choice. You give them the pros and cons of every surgery that you have. And basically, it's the patient's choice. If the patient has mild cataract, then I think the choice is pretty obvious that we're going to do a lens replacement. But if the patient doesn't have cataract and it's of age, let's say of 60, and it still has no cataract, and I think it's a patient's choice there.
Well, gentlemen, we're going to have to go beyond this second poll to the third poll, if you will. We've got the results of the second. Let's go right up to the third poll now. All right, we're into it. So, how do you manage plano presbyopia? It's the question on the floor at the moment. And audience, please go ahead and respond. All right, we're seeing some numbers live. Interestingly, no surgery is inching ahead. That's still moving though. But followed by presbyopia correcting IOLs, followed by Presbyopic. So very interesting results indeed. We're gonna let it ride for a few more seconds. But panelists, what do you think about that? No surgery followed by, again, presbyopia correcting IOLs and then Presbyopic. Any comments on the floor?
So I think that brings me back to my original point. If you do have the ability to perform Presbyopic, obviously you do need a Zeiss laser to be able to do that. It does allow you to then treat plano presbyopes with greater confidence, because they will be happy. They will have high degrees of spectacle independence. It's a very safe procedure, and they will have very high quality vision post-treatment.
Fantastic. Well, that's it for the polls now, gentlemen. I just want to get into a few other questions before we move on to the second part of this discussion. Last few questions. Is there anything special to consider for treating patients with presbyopia correcting IOLs who have had previous laser vision correction? Any thoughts on the matter there?
I have a couple of rules, well, more than a couple of rules. And the number one rule at the start is that they have to have realistic expectations. So number one, these patients are used to, for the majority of their lifetime, to having complete spectacle independence. So you do need to be realistic with them. You need to set realistic expectations at the start. And then the other things I look for are the ablation has to be regular. There's no significant higher order aberrations. There's no significant dryness of the eyes or dryness that can't be treated. And I also usually like for there to be sufficient corneal thickness to be able to perform an enhancement post-operatively should there be a refractive surprise. Obviously, with new IOL power calculations and now with the use of total keratometry, our accuracy is much better with regards to that.
Perfect. Well, question number two I have is, which presbyopia correcting IOLs do you implant in occupational night drivers? So, we see a lot of lorry drivers around Asia Pacific, taxi drivers worldwide for sure. What do you find?
I actually put in a trifocal as well. It depends on the patient, what the patient wants. I explain all the risk and all. I show the patient how actually it will look on a picture, and usually you will get adapted to it. And generally, they're doing fine with trifocals as well. But of course, if they want to be on the caution side, they can have an EDOF actually. I mean, it's good for night driving, and you can see dashboard and all those. So that's about for me. Yeah.
Fair enough. And finally, is there any patient group, any special professions out there where Presbyopic would offer even more advantages than for standard patients, let's say?
So the first thing that I'm thinking about, and Amir can tell me if this is true, is that as far as I know, an airline pilot cannot do or cannot use a multifocal lens, so it would be a problem for him. So maybe in the future, the development of EDOF would make them able to do it. But until now, Presbyopic, I think it's a very good choice for them. And as I know, British Airways allows the pilots to have Presbyopic. Is this true, Amir?
Yeah. So the Civil Aviation Authority in the UK allows Presbyopic for commercial pilots, and therefore we get lots of commercial pilots having Presbyopic in the UK. They can still have a presbyopia correcting IOL, but they have to have significant post-operative evaluations in order to be allowed to fly afterwards. So Presbyopic is a much simpler option, much more straightforward for them.
Because if they find out that they cannot pilot again, it will be a real problem, I think. And the solutions to solve those problems are very limited. So, yeah.
All right, panelists. Well, you've done a fantastic job. We're heating up here in the middle of the hour almost. We're into the second part of the discussion now, and that refers to, how would you handle common challenges in treating presbyopic patients with specific needs? Okay, so for example here, beyond age group and demographics, we're also looking at other patient-specific considerations that would need to be resolved with either surgical solutions or other solutions. And we're talking again, about corneal refractive treatments to different IOL technologies. How do you handle these challenges to make happy presbyopic patients? Okay, so let me get into an example here. Let's say a patient comes in that has bad tear film and overall perhaps dry eye. How would you handle these patients with the types of treatments that we're offering today?
Well, for me, I treat the dry eye first, though. I don't do the scan straight away because if I do the scan, I know it's not going to be accurate anyway. So for me, I'll treat the dry eyes, wait for about 2 weeks, and if it's okay, then we proceed with the surgery as it is. But I do warn the patient that this depends on whether your eyes are still dry on that day. If it's still dry, I'm going to repeat it again. So for me, it's a postponed kind of thing.
It's the same, yeah. I think the quality of our diagnostic imaging is impacted by the quality of the ocular surface. So that needs to be optimized even before making the evaluation, and certainly before discussing the options for treatment and then performing the treatment.
So this is the way.
The only way.
Yeah.
I was just going to say, Andre, I really like your house behind you. It's lovely, isn't it? Private practice in Romania is obviously very successful.
Exactly. So even I have a statue in front of it. So I'm happy every morning.
Fantastic. Well, gentlemen, we've got another question on the floor. Patients with previous eye surgery. Now, we've talked a little bit about this previously on this webinar, but what do you think about previous eye surgery overall and how it impacts any of the choices here?
I think it depends on what type of previous surgery we're talking about, though. Talking about, let's say a pterygium, even a pterygium, a simple one.
Yeah.
Yeah. So the experience is that even though a patient had pterygium surgery, a recent one, I wouldn't want to do it straight. I would repeat the biometry again, and let's say once, and I think after that 2 weeks later, I would repeat again to make sure that it's actually it's stabilized rather than I just do it because there was bad experience where it continued to actually change. So the post-op outcome wasn't that great.
Well, let's just go on to patients with thin corneas. All right, we see these patients sometimes, right, in practice pop up. How would you address these patients with the options today?
I think it's the same with any refractive patient. You assess them on an individual basis. The corneal pachymetry in of itself doesn't always limit you in terms of the treatments. Certainly for corneal laser eye surgery, the more modern ablations are very tissue preserving. The Visumax can allow you to perform very thin flaps very accurately. So it's not as limiting as it used to be in my experience.
There's an interesting question that popped up from the Q&A chat, and I was trying to figure it out for a little while, but now I completely understand what they're trying to get at. It says Presbyon or IOL for eye surgeons. And I realize they're talking about literally, what would you do if your patient was an eye surgeon? Presbyon or an IOL correction. What would you guys want to have?
If you look back, the number of, as far as I know, and the number of eye doctors who had the multifocal lens in, it's very low. As I'm pretty sure that the number of eye doctors who had presbyon on their eyes, it's particularly higher.
So I think just to add to that, what I would say is it depends. Obviously, it depends on whether the patient, the eye surgeon has a clear lens or not. If they have a clear lens and they're young, you would follow the same default protocol. What is great for our patients is also great for us. That's what I would. I don't think that's any different.
Glad to hear that.
Yeah.
Yeah, and I think that when treating patients, that's what I tell them, that I want to treat their problem with as minimally invasive technique possible. So of course, my first choice would be always a corneal procedure. And then if we cannot do that from one reason or other, we go next level.
Well, great. Well, what if the patient has some kind of visual phenomenon or neuroadaptation issues? Any thoughts on this type of patient?
Again, that would depend on what exactly you mean by that. I think what is great with Presbyon, although you can do it in multifocal IOLs, you can simulate the effect of Presbyon with a cross blur test preoperatively, and that works very, very well. And you can then tell what a good candidate would be. And we know that with Presbyon, more than 90% of people are able, within the set parameters of Presbyon, will be able to tolerate and accept that.
Okay, and final question from this line on the floor. Don't shoot the messenger if this is too vague, but what about patients with other comorbidities? I don't know if that includes COVID, but let's consider comorbidities for a moment.
I don't know. I mean, if you mean ocular comorbidities, again, we know that we can assess what visual potential is with Presbyon, even with a lens exchange procedure, and that will guide us. A laser vision correction procedure obviously has no impact on macular function or optic nerve function, so that's something that's worth considering if you mean ocular comorbidities.
It depends on what kind of ocular comorbidities you're talking about. If it's diabetic and he has diabetic retinopathy and things like that, even dry eyes, it depends on what kind of comorbidities we're talking about.
You're all reading my mind. I'm thinking ocular comorbidities, DME, whatever floats your boat at the moment.
Yeah, I think that having, as we said before, more solutions help us to make the right choice. If we're talking, because the first thing that came into my mind was, Presbyon is a LASIK procedure. So of course, the dry eye is the most important thing if we are talking about a healthy cornea. And we have to manage this before in order to be able to provide the patient with the procedure.
I think the rule here is first do no harm to the patient. Yeah. So it depends on the patient's condition.
Well, you'll be happy to know that we have another poll coming up in just a moment. And it's not regarding whether to do harm or not. It has something to do with something else. So let's see. Let's pull that poll up here. Do you use presbyopia correcting IOLs in patients with dry eyes? We're polling the audience here. And it had pulled even, and now it's going in opposite directions. The no appears to be the strongest answer. That's interesting. So what do you all think about that? That in fact, the answer is largely no.
I would say that we actually can treat the dry eyes first, then you put in your presbyopic correcting lens. You still can do that all the time. It's just that the patient have to continue the treatment of dry eyes after that. So to me, it can be a yes, it can be a no. It depends on the patient as well. I put it in all the time for dry eyes patient actually, but we have to treat the dry eyes first.
I guess it means that nobody's moving their clinic to the middle of the Sahara either. That's probably a good idea.
We do the same. We treat and then we use, because people need help. They want to have a good vision. So we are there for them.
Well, great. We have last poll of the day, poll number 5. And the question is, what are your limits to treat hyperopic patients with a corneal-based approach? Audience voting as we speak. And actually, I'm treating up to 3 diopters is actually pulled even for the moment.
Yeah, and I think that's down to sort of manufacturers' recommendation and sort of regulatory requirements as well. although based on your nomograms and your experience, you can, and individual patients treat higher. So it is perfectly reasonable to do that.
Very important to understand and to make the patient understand that hyperopia is more difficult to be treated and enhancements might be needed, and you have to set their expectations. But as you all know, hyperopic patients become very, very unpleased with their vision as they grow older. So I think we have to try to find a solution also for them. So that's my point. You have to talk to him and set his expectations for the future.
Panelists, we're now into the third and final part. What would you recommend for surgeons who are dealing with presbyopic patients overall? And so, that's sort of the theme of the discussion. I'm going to be asking a few customized questions, though. So, we know now that there's a customized LASIK treatment for patients with presbyopia in absence of cataract. Just tell me a little bit more behind, what's the philosophy behind this? Why is this important in our day and age?
As I said before, I would always recommend and I would choose a minimal invasive technique. So there were performed more than 55 million, I think, procedure of LASIK. It's a long history, a lot of experience and great equipment. So it's a very safe surgery. Basically, Presbyopic is based on LASIK. So you can tell the patient that, I had for your kids LASIK, I had for your kids Smile, and now I have Presbyopic for your eyes. So it's very easy and friendly procedure. So also, I think very important is that it keeps and improves the remaining accommodation. So the patient will still have an active vision.
All right, so a procedure like Presbyopic combines the simplicity and accuracy of corneal refractive surgery with the benefits of extended depth of field, or EDOF, as we've come to know, while retaining visual quality, future adjustability, reversibility, and EDOF benefits if cataract develops in the future. And whew, that was a mouthful, but can you explain a little bit further why refractive surgery plus EDOF benefits are of high significance?
It is a very tried and tested procedure. We know it's very safe. LASIK's been around for several decades now. Tens of millions of people have had it done. What we are doing is we're not inducing a multifocal type cornea, but just extending the depth of focus by manipulating spherical aberration to a level which allows good quality of vision while giving you that slightly enhanced range of vision. The other added benefits is, of course, it's easily reversible. So, if you have trouble driving at night, you can just have a pair of driving glasses in the car. You can enhance it very easily just with a flap lift. And, if you do develop a cataract in the future, all you have to do is use a monofocal lens in either eye with the same refractive targeting that you did before. The extended depth of focus, the spherical aberration that you've induced on the cornea remains and is there lifelong. So those are the benefits, I think, in summary, that I would say to that question.
Well, we interrupt this live broadcast to bring you another question straight from the audience. So Wayne Crew Brown asks, how do you explain to patients who had non-cataractous lenses with incapacitating glare, halos, and dysphotopsia why you did not recommend Presbyopic?
I don't think that we would have a problem with that, because our idea is that we have to give all the patients before having the decision the access to knowledge. So for instance, what we do, I have a web page which is called something similar in Romania, like Get Rid of Your Glasses. So there we have very well explained in patients' language what they have to know about their procedure. So after the consultations, I give them the link and I tell them, look, read about it, you will have films. And then approach me so we can discuss and choose the right option. Sometimes I push for a procedure and the patient wants to go for another. So it's easy. If he chooses multifocal and he's unhappy, I will tell him, I told you Presbyon is better on this because you have better quality vision. So the discussion with the patient before, it's very important.
Yeah, so I think, yeah, it's a very good question, Wayne. Slightly loaded there, but but what I would say is that it does come down to the ability to provide all the possible solutions to your patient's problems, and having the correct informed discussion and therefore informed consent for whatever the procedure. The other thing I would say is, although disabling glare and halos does occur in presbyopia correcting intraocular lenses, it is not as common now as it used to be with older generation intraocular lenses. So those are the important points that I would make.
I got a text. Dr. Mohammed Qureshi says, I think corneal surgery is not as safe as it was mentioned, especially for presbyopic correction. The more we operate, the more we see untoward effects. Do you think so?
At least in our experience, the platform that we use provides us with great safety. So, my history in refractive started with PRK first, and then I moved to doing LASIK, and then I started to do SMILE, and then I started to do Presbyon. So I think it's as safe as it can get, this laser vision correction procedure, as long as it's well recommended. I mean, the preoperatory assessments are well performed, and you take the right choice for your patient.
I would concur with that wholeheartedly. You're always going to have the possibility of complications or unwanted results from surgery, but I would say that is exceptionally low in laser vision correction, especially if patient selection has been done meticulously.
Well, if you compare to intraocular surgery, as in cataract surgery, I think it's safer to actually do a corneal surgery, actually. Yeah. Risk of infection and things that happens after that. In cataract, you still get your retinal detachment risk and all. So I think it's actually safer to do a corneal surgery instead.
Well, I'm going to get long-winded for the moment and talk over the next questions of our attendees, so feel free to relax as I give a little monologue here. So, Presbyon uses a personalized ablation profile for customized treatments based on the naturally occurring spherical aberration of the eye, factoring in the functional age and degree of ametropia to improve on conventional modified monovision, and instead produces modified binocular vision with preservation of stereo acuity. All right, we've got an SAT question now. Let's unpack this a bit. So discuss why this personalized ablation profile is helpful. That's what I really want to know.
That's a highly technical question. I'm not sure we have enough time to answer it. But what we're saying is we assess the patient in terms of their ocular spherical aberration and their functional accommodation. And that allows us to perform a micro monovision type treatment, but we blend the two eyes together based on those factors, extending the depth of focus for the distance eye and the near vision eye. And with both eyes working simultaneously, that gives them, full range of visual performance without any significant levels of compromise. That's the short answer to that.
Follow-up question. Why is modified binocular vision with stereo acuity critical?
I think it's obvious. We were born to have stereo acuity if we are talking about healthy eyes, healthy vision. So we want to improve the patient's life without losing anything, if possible. So losing stereo acuity, it should be a real problem. So that is the problem with the monovision, because that gap between the vision of the two eyes might lead to the losing the stereo acuity. So I think it's mandatory to keep all the functions active.
And Anonymous has invaded our webinar yet again. So, if your patient develops a cataract after Presbyon, what is your choice of IOL? What's your preferred IOL formula for these patients? And should you target emmetropia or a little myopia?
The idea is that Presbyon provides the solution also for cataract surgery. So the optical aberrations induced by Presbyon would be used with the implantation of a monofocal lens, targeting the same parameters as you would target before to keep what you have gained through Presbyon.
In terms of the IOL formula, I tend to use Barrett, but you can use Barrett, Kane, or Evo with total keratometry. The other thing that I would add to that is, because you've induced spherical aberration on the cornea, you don't want to use an aberration correcting monofocal intraocular lens. You want to use an aberration neutral one.
Yeah, of course.
Would you go emmetrope or little myopic?
Well, you're trying to go emmetropic in the dominant eye and minus 1.5 as before in the non-dominant.
Yeah.
Gentlemen, it has been said that broad IOL options allow surgeons to adapt to his or her treatment options depending on the patient's situation, to provide spectacle independence, happy patients, and broaden the treatment range. What are your thoughts on that, the sort of a broad IOL armamentarium?
But like I said just now, the mix and match thing with this huge broad options that is available. So what I do is usually ask the patient what they need, what they want to see. I would test the patient's distance of vision and also see what kind of lighting they are having. And with all this information, it's sort of tailored to the patient. So it depends on what the patient's occupation or what they do all the time. So if you're always on the go, of course, trifocal will be good. And if you are a CEO of a company who really just signs some documents and plays some golf, I think EDOF will be actually a very good choice. It depends on whether the patient is happy with the first eye. If it's not happy with the second eye, I mean, if it's the first eye, then I'll mix and match it if it's necessary. But most of the time, the patient will be happy with the first eye already, almost 95% of the time. So there's that 5% that actually you only need to sort of fill in the gaps.
Now, a trifocal might be for a patient wanting maximum spectacle independence, but who doesn't often perform outdoor activities at night and accepts compromises with dysphotopsia? Any thoughts on that?
Actually, most of the time, the patient will be able to adapt to it. It takes about 3 months to 6 months, sort of. I'll tell them to actually try to bear with it for the time being. If there is some residual power refractive error, then you may need to wear specs at night to drive. But otherwise, I think you should be spectacle independent and you wouldn't have much of adaptation problem in the daytime though. And with the COVID situation now, I don't think you should be going out much. So at night driving wouldn't be a big problem now.
Yeah. I tell the patients that if I would be able to choose a superpower in my daily work, it would be to make them forget that they had surgery and make them not to expect anything. Go with the flow and you will get used to it. Trifocal lenses that we use are amazing. We use it for many years. So,
speaking of things that we want to forget, we probably also want to forget that we're in the middle of the pandemic, but unfortunately, we still are. So therefore, another question on the floor, does anything offered here today change in light of the pandemic? Do any of these procedures have implications, positive or negative, in relation to performing them during this pandemic era?
I've realized that people are taking more care of their health and vision. So the refractive numbers increased. That's what I've seen.
Especially in this era where there's a lot of computers and handphones and all these are involved. So they realize that, oh, the presbyopic problem is here. Yeah, so that's where they come to us, I guess.
Yeah, see, I think I agree. It's twofold. Their visual performance is brought more to the fore with the use of particularly intermediate vision devices, and they have more disposable income, and people decided to invest in themselves as opposed to anything else. So I think there is a good outlook for refractive surgeons, certainly in the near to medium term as a result.
Some of you have hinted about this, but what do you think is the importance of integration slash digitalization in helping surgeons to ease patient selection and treatment in the post-coronavirus era as well?
I think during the pandemic, when we were on lockdown, we had a lot of patients approaching us with, asking for simple things. So we have implemented online evaluation for the patient and we use it. I have 1 day a week that I do that, and people approach us. We can discuss about procedures. Then they can go to the clinic to other doctor, not especially me, to do the assessments. And then if they feel like and they need, we can have another chat and discuss the details. Before that, they all wanted to come to be seen by me for me to perform everything. So I think that this improved a lot the workflow.
All right, this is a multifaceted question here, but bear with me. Let's consider several diagnostic aspects such as OCT, topography, tear film, corneal thickness, epithelial map. How do these things in diagnostics affect the chosen IOL surgery?
What I would say is they give you information that allows you to tailor the treatment to the patient's requirements. They, in of themselves, each particular piece of information doesn't determine the IOL choice that you're going to use, but may influence the ultimate IOL selection depending on what the patient's visual requirements are. So for example, if they have some mild epiretinal membrane on the OCT, you may not necessarily want to use a diffractive intraocular lens. You may decide to do, micromonovision if they have cataract. Those kind of things you can consider.
And by the way, is there less error due to integration for IOL selection using certain digital workflow procedures? I mean, yes or no, pretty much.
Yes. I would look at EQ Workplace if you have the time.
Well, does anyone have any final comments to wrap up? We're coming here at the end of our webinar.
No, I'd just say thank you very much for inviting me. It's been a real pleasure to speak with my esteemed colleagues today. And, the future presbyopia correction is really exciting indeed. Thank you very much.
Thank you so much. It's the same. So happy to be here. And I think that, we would be able to talk about what we do for hours. So 1 hour shouldn't be always enough. Thank you so much, and keep up with what you're doing. Nice event.
Yeah.
Well, we all haven't had a nap like Dr. Janbon Chan before the webinar, so but most of us, yes.
Thank you very much for inviting me as well. Good to see everyone. Hope everyone is safe. Hope to meet you guys in person one day.
Soon.
Soon, yeah.
Exactly.
Well, everyone, thanks for joining our refractive news roundtable on the secrets to happy presbyopic patients. I'll remind everyone this was the first of a 4-part Anchorman series on advanced refractive and surgical corrections and other procedures. So do join us next time. Until then, stay classy and see you soon enough.